CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Hello, everyone. Welcome to our WIP. I would like to begin by acknowledging that I am based and we are based, most of us, in the ancestral unceded territory of the Coast Salish people. And we are committed to proper care of this land in a good way. I would like to introduce our speaker today, Dr. Ehsan Karim, who's an assistant professor in health data science at the School of Population and Public Health, UBC, and most importantly, a scientist at CHÉOS. He started at CHÉOS first and also then joined the School of Population and Public Health. Ehsan's also a Micah Smith Foundation for Health Research Scholar. Actually, it should be called Micah Smith Health Research BC now, and an associate member of the UBC Department of Statistics. He has a PhD in statistics from UBC, and then he did a postgraduate training at McGill University. His current program of research focuses on developing causal influence and pharmacoepidemiological methodologies and an application of data science approaches in the large healthcare data that is available to us. And today, because machine learning makes it easier to work with large databases, he's going to talk about use of machine learning estimators in residual confounding control in pharmacoepidemiologic study. Welcome, Ehsan.
Thank you. Thank you for the nice introduction. Can I just check on the room? Like, can you hear me even from the back properly? Okay. It's nice to be back. So, as you know, I started at CHÉOS as a scientist, and now I'm at the School of Population and Public Health, as I mentioned, but I'm still a scientist at CHÉOS. So, thank you for inviting me to this WIP seminar, and today I'm going to talk about use of machine learning estimators in residual confounding control in pharmacoepidemiologic studies. I should warn at the beginning, this is a very methods-heavy talk that I'm going to give you today. So if you have a headache at the end of the talk, don't blame me, I warned you before. Okay. All right, so this is the outline that I'm going to follow. At first, I'm going to talk about why proxy variables are necessary often to adjust in observational settings. Then I'm talking about high dimensional propensity score. And then I'm going to talk about some of the machine learning version of the high dimensional propensity score that I proposed earlier. And that will lead to some new developments in the literature about use of double robust estimators and the cross-fit estimators. And using a special simulation called Plasmode Simulation, I'm going to show you some results. And from those results, I'm going to conclude. All right, so first, I'm going to motivate this talk by just talking about why we sometimes need to adjust for proxy variables. This is not necessarily a new concept. Whenever we are talking about principles of confounder selection, this is a picture from Vanderwillis 2019 paper where he was talking about selection of confounding. And in those selection of confounding, he mentioned about a criterion known as modified disjunctive cause criterion, where it says that if you have an unmeasured confounding, you can try to address or reduce the bias due to those unmeasured confounding by adjusting for a proxy variable. That's not necessarily a new concept in epidemiology. So to motivate the talk a bit, let me work with the open data source that I have been using as a toy example for the analysis that I'm going to show to compare a couple of the methods that I'm introducing here. So just to give you a brief understanding of what the problem that I'm dealing with, the problem is whether obesity is causing diabetes. right? And obviously in this particular data source that I'm using, this is the National Health and Nutrition Examination Survey, or popularly known as NHANS. I'm going to use NHANS data to assess the relationship between obesity and diabetes. This is an observational data source, and we need to adjust for confounding, right? And to address for confounding, I'm selecting a couple of the demographic, behavioral, health history, or access and laboratory type of variables that I could found in that particular data source. The issue is, this is an observational data source, right? And this is not a randomized clinical trial where we can just do a crude analysis and get done with it. We have to be very careful about our confounder selection and confounding adjustment. Even though I have selected a bunch of covariates and confounders here, in an observational setting, you never know whether there would be any residual confounding that still needs to be addressed, right? So in an observational study, we always need to be very careful about what type of variables we may not be addressing and what type of methods we are addressing. All right, so this is a tweet that came out a couple of days ago based on a paper that recently got published. And in that paper, it was claiming that even if we have unmeasured confounding or residual confounding, we can simply use propensity score to get rid of that. The problem is this is not true. Even if you are using fancy methods, more than regression methods, even if you are using propensity score methods or whatever other methods you are thinking about, you always need to be worried about this unmeasured confounding or residual confounding, right? So obviously this propensity score methodology is not equipped to deal with unmeasured confounding. In fact, one of the main assumptions of propensity score analysis is that there is no unmeasured confounding, right? Okay, so what can we do? We have selected a bunch of covariates already. Can we do better? So within the enhanced data, similar to the administrative data sources, they also collect some ICD-910 codes based on the prescriptions the participants were taking in the past 30 days, and an interviewer collects those information, and somebody who is familiar with the ICD-910 code then converts all of these codes to ICD-910 codes. So these are basically the prescription history for that person. So based on that history, you can try to get a general sense of whether this person has anemia, whether this person has any other diseases and stuff like that. And then based on all of these covariates, we can try to create a variable that can try to get a general sense of the disease burden each participant has, right? So we can basically do a Charson comorbidity index or some of the other comorbidity index, or we can be very simple. We can just simply count and try to see how many prescriptions this person takes to get a general sense of the comorbidity burden. All right, and one thing we have to do, obviously, because these are a huge list of ICD-910 codes that are available out there, we cannot just take in everything. We just need to be a bit more careful. So for example, some of these ICD-910 codes that were associated with diabetes, which is our outcome, we should not be including those in our covariate list. So we were not including those in our analysis. All right, so sample size is always a problem. So what we have done is we have merged 3 cycles of the data. The first cycle was from 2013-14, second cycle was from 15-16, and third cycle was from 17-18. We merged all of this data based on the investigator-specific covariates, and then we merged the data set with the prescription data. And we, because our study is not about missing data imputation or anything like that, we tried to make it simple about the comparison of methods. That's why we only considered the complete case analysis, and we were not even trying to make a inference about the whole population, so we did not use any survey features for weights. So in total, we got the sample size of slightly over 7,000. And in terms of the confounders, we had 13 demographic, behavioral, health history related variables. Those are mostly categorical variables. We had access to 11 laboratory variables that were mostly continuous variables. And we did end up 126 additional covariates that was based on the ICD-910 codes that were available in that particular data sources. And for the purposes of simplicity, we simply counted them and considered them as a very crude way of aggregating the information of disease burden. All right, so that's our data sources. So this is the data sources that I'm going to use throughout my analysis, but let me introduce some of the methods by which I'm going to compare the treatment effect estimation procedure. So this is a picture from a paper by Schneeweiss from 2019, where he tried to motivate why it is necessary for us to consider this ICD-910 covariates. So in general, whenever we are trying to develop a study, epidemiologic study, what we try to do is we obviously have all of this massive amount of ICD-910 codes, but we only use the necessary information that are associated with our known outcome, known exposure, and known confounder variables. All of the rest of the ICD-910 codes we generally do not use, right? So, but what Schneeweiss was suggesting is that whenever we are dealing with administrative data or observational data sources, we are always at the situation where we may not have the measurement of necessary confounders, right? We may have access to many of the confounders, but there is always the situation that some of the confounders are not there, right? But there is this additional ICD-910 codes that do not necessarily go with the study because we do not necessarily know how to interpret them in the context of our study, so we get rid of them. What Schneeweiss was proposing is that why don't we use the data, because these data and these variables are coming from the exactly same patient that we are including in our study, and we have this massive amount of information that we are not really using, so why don't we just use it? And he came up with a strategy of using those analyses without making the regression overfitted. All right, so based on this citation graph, you can see this paper was originally published in 2009, and every year this paper is getting more popular and popular, and everybody is citing it, everybody is using it. So why is this method getting more popular and popular? Because maybe it works. Okay, so let me explain what this method is about. So obviously, for any kind of study, we have a cohort entry date and we have an event until which we are following that patient, or there is an administrative date until which we are following up the patient. Before the study start, we can define a covariate assessment period of maybe it could be 2 years, 1 year, 6 months, whatever it works for you. And within those covariate assessment period, we can try to accumulate these ICD-910 codes that we may have available in our data sources. Say, for example, in a regular administrative data source, usually the general practice data, diagnosis data, procedure data, say, for example, whether you took X-ray or not, medication data, all of those are usually available, and those are massive sources of additional information that we could have used in our analysis, right? All right, so from each of these data sources, what we do is we try to take a look at, say, for example, anemia. For that, what kind of treatments or medications people were using, and then we try to, because these informations are continuous information, and it could be hard to deal with all of this discrete continuous information separately. So what Schneeweiss proposed is that instead of considering all of this information as a count variable, why don't we use binary variables? But then again, binary variable might be too crude because we are just dichotomizing based on just one category. So he proposed, instead of categorizing based on just one category, why don't we categorize based on 3 different categories or cut points, and then we try to see how many additional covariates that we can accumulate. So for example, for the first row, you can see there is this ICD code D64.9 is the code for anemia, and then we can categorize based on whether that code appeared at least once, and whether the code appeared at least more than the median, and whether the code appeared at least more than the 75% or the third quantile. here. And based on that, we try to create 3 separate binary variables. So essentially what we are doing, so for example, in our study, we had 126 dimensions or the ICD codes. And then we are converting each of these 126 ICD codes to 3 instant intensity binary variables. And then we are trying to take the most prevalent codes, because like in some of these codes, you will see just 1 person was there or 2 person was there. So those are probably going to create more sparsity in the data. So what Sniva suggested, just work with the most prevalent codes. Usually it is suggested top 200, but there is some dispute about that as well. So whatever number works for you, just do not take any variable that has very low variability. That's what the main idea is. So let's just take a look at how these variables look like. Obviously, we are talking about various binary variables that we are creating. So eventually you will end up some binary variables that looks like this, and you are just going to aggregate all of this information with each of the patients from which this additional informations are coming from. All right. So, okay, we have added all of this information, but how do I know which informations are going to be useful? Because like we have now included a bunch of covariates in our data sources, and we all know that when we are including a bunch of noise variables in our data sources, what we will end up with is a lot of variability in our estimation. So to prevent us from that, we want to select the binary variables that we have created that are most useful for our analysis, and we want to get rid of the noise variables that are not useful from our analysis. But what would be the way? Because like there is no framework by which we have selected those variables. We just took those variables because they were available, right? Okay, so to save us from trouble, there is a formula that was proposed by Bross in 1966 that actually saved us from this trouble. So what Bross was suggesting is that if you suspect that there is an unmeasured confounder, you just need 4 parameters to identify how much bias that unmeasured confounding is causing. So what are those 4 parameters? The first parameter is prevalence of unmeasured confounder among treated, prevalence of unmeasured confounder among untreated, and you have to do the same for the dead or alive or the outcomes, whether that person achieved the outcome or not. If you have those 4 prevalences, and let's just name them as P11, P10, P01, and P00. If you have those 4 parameters, you can simply plug in those parameters into this formula that I'm showing in the slide. And you can simply calculate how much confounding that particular unmeasured confounder is responsible for, right? But remember, in our case, we have the opposite problem. We do not have unmeasured confounding. We have all of these empirical covariates that we have created, all of these binary variables that we have already created. It's just a matter of checking for each of these empirical covariates how much confounding those variables were causing, right? So say, for example, if we have 100 or 200 empirical covariates, we can use this formula to calculate the bias estimate for all of these 200 empirical covariates. And then what we can do is we can simply rank them and try to identify the empirical covariates that were associated with the absolute high bias, or the in here I'm basically talking about absolute log bias because I'm basically dealing with a very small number here. Then once I do that, I try to select the top 100 empirical covariates that were associated with high bias, and I can simply include those additional 100 empirical covariates into my regular propensity score regression as covariate, and voila, we have our high dimensional propensity score. Okay. Problem is, the way we have been calculating our empirical covariates, and we were selecting our empirical covariates, that does not take into account of what additional information that we have. It is basically very similar to univariate selection. So we are not taking into consideration of what additional empirical covariates are providing what information. We are basically checking them one by one. which is not the best strategy. The best strategy as a statistician would be we would want to check in a multivariate structure when we put them together, how much of them survive, right? So in my opinion, when I looked at this high dimensional propensity score algorithm back in the time when I was doing my postdoc, I thought that's odd. They're not taking into account of the multivariate structure of the problem, right? So I proposed a machine learning version of the problem where I suggested some of the variables that should be included in my analysis should be based on some of the guidance that we already have from our propensity score literature. So in the propensity score literature, there is a lot of literature about what kind of variables should be included in our propensity score model or not. And based on that, let me just summarize that with this picture is that there can be different roles of variables for various variables that we are considering. It could be instrumental variable, it could be mediator variable, collider. But the only two types of variables we really care about is the confounders and the variables that are highly associated with the outcome or the risk factor for the outcome. Those are the two variables that we are interested about. And what are the one thing that is common about the confounder and the risk factor for the outcome? That both of them are associated with the outcome, right? So the problem is actually very simple. What we can basically do is we can run a outcome regression model and we can try to identify the variables that are highly associated with the outcome, right? And we can simply do that by running a lasso. Lasso method is very good at trying to find out the variables that are highly associated with the outcome, and then whatever variables that are not really contributing to anything, it can assign a zero coefficient and can throw away from the regression model. So essentially, lasso method can be a variable selection method. And once we use lasso method to identify the variables that are highly associated with the outcome, we can simply plug in those methods as the empirical covariates as our high dimensional propensity score framework, and we can get very similar results. And in a simulation back in the time, I have showed that when we are using these pure machine learning methods that are within the green box here, those are not acting any differently than the propensity score, high dimensional propensity score original algorithm or the hybrid type of algorithm that are already proposed in the literature. All right, so I have already suggested that machine learning methods can be a suitable alternative to high dimensional propensity score method that is out there. But since then, there has been new development in the literature. In the literature, there has been additional proposal of using other methods known as double robust methods and some of these additional optimism correction methods such as cross-fit, right? So, and one of the things that I have not done in my previous work is that I have not checked the 95% coverage probability in that work. But since then, there has been a lot of literature about the importance of checking the 95% coverage probability and whether the machine learning methods can deal with a huge number of variable list and whether whatever method we deal with, whether they can reduce bias even in the face of too many variable adjustment. Are we really essentially subjecting ourselves to overfitting or not, right? So those are some of the new concerns that came into the literature. And obviously, the double robust methods were already popular, and I thought that it is a very good time for me to go in the direction of double robust methods and also checking this 95% coverage. Last year, there was a proposal of a cross-fitting method that is an improvement over the cross-validation method that are already known and out there in the literature. And in that cross-fitting approach, what they are basically doing is that in a propensity score method, we have two steps of the modeling. One step is the exposure modeling, and the second step is the outcome modeling. So what this cross-fitting method is doing is that it is estimating the propensity score model from one fold of the cross-validation, and it is estimating the outcome model from another fold. So that is the only difference between the regular cross-validation and cross-fitting. But in a paper in epidemiology journal last year, it was shown that when we are using this cross-fitting method, they got phenomenal results. So I was curious. They were checking in a low dimension, but this is a perfect method to assess in a high dimension, because cross-fitting is a method to deal with optimism correction. And what better application could be other than checking it in a high dimensional setting, where the overfitting is really a problem. All right. To check the performance of this method, what I'm proposing to do here is that instead of conducting a Monte Carlo simulation, I resorted to Plasmode Simulation here, because Plasmode Simulation has the distinct advantage that it preserves the association among the exposure and covariate list from a real data source. And based on this data source, we can try to identify which methods are performing better or not. The reason this is appealing to most of the epidemiologists and statisticians is that it is taking inspiration from a real data source. It is not just assigning normal distribution to this variable, Poisson distribution to this other variable. It is taking inspiration from a real data source to take into account of all of these associations that are already out there. Especially this is very important in a high dimensional setting, where the associations of all of these variables and preserving them is very hard in a Monte Carlo simulation. All right. So in this particular Plasmode simulation, what we are doing is that we are essentially at first talking about some of these demographic and behavioral variables that we considered. We're using those variables. In terms of the lab variables, remember the lab variables that we were considering in our data source were mostly continuous variables. And these double robust methods are very popular in addressing this model misspecification problem. Why model misspecification is a problem for real data analysis? Because, say, for example, you are an analyst for a data analysis, and you are trying to figure out what is the model. And basically what we do as an initial modeler, we try to include all of the main effect terms, right? Then we go back to literature to figure out what is the interaction term that is possible, and then we try to include all of this interaction term one by one, right? But in a parametric setting, the problem is that we need to specify all of these interaction terms and all of these possible polynomial terms and all of these other functional form that that should be defined out there. So as an analyst, when I'm analyzing the data, it is a lot of iteration and a lot of process. Versus when I'm using machine learning methods, this type of relationship, no matter how complex they are, depending on which method you are using, sometimes those methods have the ability to automatically detect these functional forms. So for example, in this form, I'm using the log version of a variable, and in this form, I'm using an interaction. In this form, I'm using a variable divided by something else square. In this form, I'm using some variable square divided by an interaction and stuff like that. So all of this crazy interaction and complexity that can go on, machine learning methods are very highly equipped to deal with this type of problem. But it comes with a cost. When we are using machine learning methods and highly predictive methods, usually the coverage probabilities are very low. So in that setting, what we have to do is we have to use some of these double robust methods that can regain some of these coverage probability problems that machine learning methods have. So just to be able to show that, and this is actually a realistic problem, because like in regular simulations, when people are doing their simulation with all of the main effect terms, that is rarely the case in real data analysis. We always need to take into account of all of these interaction term and polynomial term and complex terms that are out there. All right, so one other thing that was done in this particular simulation is that we were taking into account of all of these ICD-10 cores that were available, and we selected and we ranked them based on the low bias M, based on the Bros formula, and we selected the top ICD cores that were prevalent, and we summed them up to get a simple count, which was a proxy for the health status or the disease burden. So we used all of these variables in this particular form, but when we were estimating, what we did is that we used the original variables. Say, for example, this globulin variable, we did not use the transform variable when we were estimating, because in a realistic scenario, we would not know what is the relationship. So we just gave the main effect terms in the estimation stage, but in the in the data generation stage, we used all of this complex formulation. Okay, and then what we did is that we were basically generating the data based on the association that we have in these data sources, and we used the cohort of 5,000, and we did the 1,000 simulation. 920 was successful. Some of them had convergence issues. We fixed the outcome rate very similar to the original data 0.4. We fixed the exposure prevalence, which was also very similar to the original data 0.2. And we selected the true odds ratio to be 1.5, or when we convert it to the risk difference, knowing the exposure prevalence and the outcome prevalence, we got the risk difference of 0.073. All right. So these are the methods that we are using. We use two different type of method. We use the regular propensity score method without any double robust combination. So we use the regular logistic regression method with all proxies. We use the Bayesian adaptive regression method with all proxies, and then we use the propensity score model with the lasso selected proxies, and we use the high dimensional propensity score algorithm with the high dimensional propensity score selected proxies. And then we had another version of these estimates with the TMLE, with all proxies, with the cross-fitting, with high dimensional propensity score selected covariates, and high dimensional selected proxies with cross-fitting, and we have done the same for the lasso selected proxies with the cross-fitting. In all of these scenarios, we have, as I have mentioned earlier, we have used the original lab variables. So globulin, we just use that as the main effect term. When we generated the data with the transform term, and instead of giving a summary of the variables, we used all of the binary proxies from the original data, because we do not know which variables in reality, which variables would be useful or not in our case. So in this particular simulation, we added a lot of noise variable actually when we were doing the analysis, which would be the case in a realistic high dimensional propensity score analysis setting. All right, so moment of truth. All right, so here is the result. You cannot see the bottom part. This is basically the bias without adjusting the proxies, and you can see the bias amount goes to, this is in the risk difference scale. So bias amount can go to minus 0.112. For the TMLE, BART propensity score and the propensity score method. But as soon as we use the proxy variables, you can see the bias amount goes down to minus 0.06, even for the most biased method. And let me spend some time in explaining what are the methods that I'm using. Let's start from the bottom. At first, I'm using the propensity score method, and then I'm using the BART propensity score method, and then I'm using the lasso propensity score method, and then I'm using the high dimensional propensity score method. And then I'm using the regular TMLE method without any propensity score, without any high dimensional propensity score selection with all proxies. And then I'm using the cross-fitted version of the TMLE. And then I'm using the high dimensional propensity score version of the TMLE. And then I'm using the high dimensional propensity score version of the TMLE, but with cross-fitting. And then I'm using the lasso version of the TMLE with cross-fitting. All right, so it can hurt a bit. So it takes some time to get used to what I'm looking at. So, but these are the methods that I'm comparing. And just by looking at the bias scenario here with proxy, you can see the methods that were associated with TMLE with or without the high dimensional propensity score algorithm are doing much better compared to the other methods. So I'm basically talking about this method and this method, right? All of these other methods that were associated with the cross-fitting, you see these methods are associated with high amount of bias. right? So if you just look at this bias plot, and you can see the high dimensional version of the TMLE and the regular version of the TMLE, these methods are winning, right? And then when we are taking a look at the empirical standard error, I'm sorry, you can take a look at the bottom part, but just trust me on this. This is the empirical standard error there. And in terms of the empirical standard error, one thing you can see that the regular version of the methods that used any kind of variable selection, say for example, the high dimensional propensity score or lasso method, they were associated with high amount of standard error. But all of these other methods, including the cross-fitted version, they were almost performing very similarly. The problem begins when we try to estimate the averaged model standard error. So though these standard errors are coming from the models, we just made an average out of them. You can immediately see whenever we are estimating this average model standard error, the cross-fitted versions of the average standard errors are much higher compared to any of the other methods. And the implication for that is that when we are trying to take a look at the relative percent error in the model standard error, you can see the cross-fitted versions are off the chart, like those are going crazy. But all of these other methods are almost performing very similar whenever we are comparing the model standard error and the empirical standard error. Okay, so if you look at the coverage, remember, like the only reason we were using the double robust method or the TMLE method is that we wanted to get improved coverage, right? And when we look at this plot, you can basically see the cross-fitted version are doing very well in terms of coverage. Even with some of these TMLE version of the method, they are not doing as good as the cross-fitted version. But this is a trick question. These coverage probabilities are coming from some methods that are biased. So these coverage probabilities that you are looking at are not really depicting the true picture. The true picture would probably come from a bias eliminated coverage plot, where you can see the cross-fitted version of the TMLE methods are not doing as well as the not bias eliminated coverage plot. And in this particular plot, you can basically see the hdPS TMLE or the TMLE methods are actually doing better. But some of this, you have to be a bit careful about interpreting this plot, because like you can see some of these propensity score original methods are doing much better, but these are biased methods to begin with. So this plot needs to be interpreted with some caution. Okay, let's just go back to the original method that we generally are familiar with. If you try to compare in terms of the mean squared error, then you can basically see the hdPS version of the TMLE and the original TMLE methods are winning. This is very similar to what we have seen in our bias chart, that the TMLE and the hdPS version of the TMLE are doing very well. All right, so like that's the end of the pain, results are end. So here we are at the very last slide, where I'm just going to summarize what I have seen in terms of my results so far. All right, so it is already well known that double robust methods are very good, especially when we are dealing with a scenario with complex functional form. And this is very good property when we are dealing with realistic data sources, because often we do not know the true functional form of the specification, and we just try to figure out what could be the specification based on various diagnostic plots. Right? So in that case, this double robust method or the TMLE method can be a game changer. And also, we have also known from the literature previously that the proxy adjustment is helpful, especially when we are suspecting there are some sort of residual confounding bias in our analysis, which is almost always the case in observational studies. All right, so let me just explore what we have learned from this particular study. In this study, we have seen that TMLE methods are actually very good in dealing with high dimensional proxies, especially in the scenario when we may have a lot of noise variable. So even though we do not do any kind of variable selection by high dimensional propensity score or lasso method, if we just rely on the TMLE method itself, TMLE method is actually very good at identifying the treatment effect estimate with least bias, least coverage, nominal coverage, and almost nominal coverage, and low mean squared error. So last year's paper that was suggesting that the cross-fitting method will provide us good estimates of bias and the mean squared error is something that we could not replicate in our study. We have seen that the cross-fitting methods were associated with the most problems in terms of bias and the mean squared error. But then again, this is a work in progress. That's why I'm presenting it is in a work in progress seminar. I'm still exploring this because like there are some certain parameters that were suggested. So for example, the training of the cross-fitting estimator, usually in the original paper, they suggested it to do it more than 100 times, but we did it 5 times only based on some of the other literatures that are out there, and the simulations are still learning. So whenever I know more, probably I will get to publish that and you will get to know more. Thank you. When we have a conceptual understanding of the problem, so for example, when we are trying to identify the relationship between obesity and diabetes, we generally try to, at first, as an epidemiologist, try to draw a DAG. And we have certain covariates based on that, and we can try to run a backdoor criterion on that to identify the minimum sufficient adjustment set. And when we arrive at that minimum sufficient adjustment set, on top of that, if we run a variable selection method on that, the problem with that would be we are essentially letting go some of the variables that were already selected by the minimum sufficient adjustment set. So as the name says, minimum sufficient adjustment set has to stay there. It cannot be reduced more than that minimum sufficient adjustment set. If the minimum sufficient adjustment set says that 6 variables needs to be adjusted, 6 variables needs to be adjusted, not less than that. So having a minimum sufficient adjustment set and running a variable selection on top of that is always a problematic idea. But one thing that I want to clarify a bit is that in this type of high dimensional propensity score algorithm, one thing that is often a source of confusion is that what type of variables we are trying to do variable selection on is not all of the variables. So say, for example, some of these demographic, behavioral, and history, health history type of variables are coming from a particular DAG and the minimum sufficient adjustment set. And we are not running a variable selection method on any of these variables or the transformed lab variables because those variables were coming from a DAG. The only thing that we are running a variable selection on is the high dimensional additional covariates that we generally have. So for example, if you go back to the original equation, so only these variables would be subject to any kind of variable selection. And that's why I said these are only selected variables that we are adding here. All of these other confounders, we are not running a variable selection on them. All right. Okay. And the only reason we are doing it is that when we were selecting our minimum sufficient adjustment set, we had a suspicion that there is a variable that was maybe unmeasured, and all of these empirical covariates that we are adding are supplementing for that unmeasured confounder. Okay, in terms of the second question, my general understanding is that the question was more about, is it possible that even high dimensional propensity score can miss? Okay, so this is a take that many of my colleagues in the literature do not share, but this is something that I also mentioned in my previous paper, is that even though this is a very interesting method, I do not suggest anybody to use this method as their main analysis. I usually suggest people to use this as a sensitivity analysis, where they can justify their DAG and they can do their own analysis at first as the main analysis, and then they can do this high dimension and all of this fancy version of the method as sensitivity analysis. The reason I propose that is because these variables that I am adding as additional variables as a supplement to the original variable, I have no idea whether this is giving me an estimate which is on the right side of the estimate or on the left side of the estimate. There is no theoretical basis on that. I only know these empirical covariates are somehow associated with the variables that I'm missing, right? So that's the only information that I'm assuming. So the estimates that I'm getting are going in the right direction or left direction. I can only compare that when I'm comparing that with a main analysis done with only the confounders that I have at hand, right? So that's my take. Like I do believe, hey, even hdPS method, no matter how fancy it is, it can miss a bit. But the thing to understand in epidemiology, which is slightly different than statistical literature, is that in statistics, we try to identify an unbiased estimate, which is not the purpose of an epidemiologic study. In epidemiologic study, our purpose is always to reduce the amount of confounding and reduce the amount of bias. And in my opinion, a high dimensional propensity score does that very well. But it obviously depends on the type of variables and the type of data sources you are using. If you are simply using a data source that do not have sufficient information to supplement that one variable that you are trying to supplement, obviously this method can not do well, right?